In medicine cabinets across the country, nestled among bandages and common cold remedies, a tiny, unassuming pill is taken by over 70 million people, a trusted and ubiquitous ally in the daily, often lifelong battle for heart health. This medication, Amlodipine, belongs to a class of drugs known as calcium channel blockers, and its primary role is to relax and widen the blood vessels, thereby making it easier for the heart to pump blood and ultimately lowering the crushing force of high blood pressure against the delicate arterial walls. It has become a cornerstone of modern cardiovascular therapy, prescribed with confidence by physicians and taken with a sense of security by patients who see it as a shield against the devastating consequences of hypertension, such as heart attack and stroke. But what if this seemingly benevolent guardian of your cardiovascular system, this daily dose of reassurance, holds a shadowy and complex secret, a potential for harm that is rarely discussed in the brief consultation time allotted in a busy doctor's office? What if the very medication you or a loved one relies on to maintain a healthy blood pressure could, under a specific set of circumstances, be quietly and insidiously setting the stage for a catastrophic, life-altering, and in some cases, fatal event? The common side effects, things like swollen ankles due to fluid shifts, a bit of dizziness as the body adjusts to lower pressure, or a mild flushing of the skin, are well known, documented, and often dismissed as minor acceptable trade-offs for the profound benefit of cardiovascular protection. But this is not about those minor inconveniences. We are about to pull back the heavy curtain on a far more sinister and complex reality, exposing the critical red flag warnings your body might be screaming at you this very moment, signals that are too often misinterpreted, ignored, or attributed to other causes until it is far too late. In the detailed exploration that follows, we will delve deep into the mechanisms and manifestations of 6 particularly dangerous side effects of amlodipine that frequently fly under the radar of both patients and clinicians until the damage is severe and, in some tragic cases, irreversible. One of these conditions alone, a perfect storm of systemic collapse, is responsible for sending thousands of unsuspecting patients to the emergency room every year, with a mortality rate that is nothing short of chilling. This is not the kind of information you will find casually mentioned on a standard fine-print patient leaflet. This is the crucial, in-depth knowledge that could empower you to recognize a developing crisis, to ask the right questions, and to advocate for your own safety, potentially making the difference between continued health and a sudden, life-threatening medical emergency. Thus starts the vicious cycle of Brash syndrome. Imagine, for a moment, a perfect storm brewing silently inside the intricate machinery of the human body, a catastrophic domino effect where one system's failure actively triggers another's, which in turn worsens the first, creating a rapidly escalating and self-perpetuating crisis. This is the terrifying reality of Brash syndrome, one of the most severe, under-recognized, and potentially lethal complications associated with medications that block the heart's AV node, including amlodipine, that most patients and even a surprising number of frontline physicians have never encountered by name. The name itself, Brash, is a clinical acronym that neatly encapsulates the devastating cascade it unleashes upon an unsuspecting individual. Bradycardia, a dangerously slow heart rate that starves the body of oxygenated blood. Renal failure, the sudden and progressive shutdown of the kidneys. AV node blockade, a critical disruption of the heart's own electrical conduction system. Shock, a life-threatening drop in blood pressure that leads to organ collapse. And hyperkalemia, a toxic accumulation of potassium in the bloodstream that poisons the heart muscle itself. This lethal cycle often begins with an insidious, almost unnoticeable event, perhaps a minor bout of dehydration from a stomach flu or a mild infection that subtly impairs the kidney's ability to perform their vital function of filtering waste products and electrolytes from the blood. As the kidneys falter, their ability to excrete potassium is one of the first functions to be compromised. Consequently, potassium levels in the blood begin to surge, a condition known as hyperkalemia. This excess potassium, has a direct and profoundly toxic effect on the heart's delicate electrical system, specifically depressing the sinoatrial and atrioventricular (AV) nodes, which act as the heart's natural pacemakers. This poisoning effect causes the heart rate to plummet to dangerously low levels, often well below the standard 60 beats per minute, sometimes dropping into the 30s or 40s. This sluggish, inefficient heartbeat means significantly less blood is being pumped throughout the body, leading to systemic hypertension or low blood pressure. This very hypertension then delivers a second, devastating blow to the already struggling kidneys, which are exquisitely sensitive to blood flow. Deprived of the adequate perfusion pressure they need to function, they begin to fail even more acutely, causing them to retain even more potassium, which in turn feeds the vicious cycle, further slowing the heart and dropping the blood pressure. The heart's own internal electrical pathway, the AV node, becomes progressively blocked by the combination of the drug's effect and the hyperkalemia, further throwing its rhythm into chaos and preventing any escape rhythm from taking over. This entire pathological process can quickly spiral into profound cardiogenic shock, where the heart is simply unable to supply the body's vital organs, the brain, the liver, and the kidneys themselves, with the blood they need to survive. An in-depth analysis of FDA adverse event data paints a grim and sobering picture. The mortality rate for patients diagnosed with Brash syndrome is a chilling 5.7%, meaning that nearly 1 in every 17 people who develop this catastrophic syndrome will not survive the ordeal. Furthermore, a staggering 20% of survivors require long-term renal replacement therapy, tethered for life to dialysis machines that must perform the life-sustaining function their own failed kidneys can no longer manage. Even more alarmingly, up to a third of all patients who present with Brash syndrome need temporary, and sometimes permanent, pacemakers surgically implanted into their chests just to mechanically force their hearts to keep beating at a rate compatible with life. Detailed case studies published in medical journals have vividly illustrated how this syndrome can be triggered in vulnerable patients, particularly the elderly who may be on multiple medications, when they become dehydrated or develop a simple urinary tract infection, turning a common and usually benign ailment into a desperate life-or-death struggle within a matter of hours. Thus darned the unseen overgrowth of gingival hyperplasia. While you diligently take your daily dose of amlodipine with the intention of protecting your heart and blood vessels, the medication could be simultaneously launching a stealthy, disfiguring assault on your smile and oral health. Amlodipine-induced gingival hyperplasia, also known as gingival overgrowth, is a deeply troubling and psychologically distressing condition where the gum tissue, for reasons not yet fully understood, begins to grow uncontrollably, proliferating and expanding to create a host of serious oral health problems that extend far beyond simple aesthetics. This insidious overgrowth can fundamentally transform the entire landscape of your mouth, burying teeth under mounds of firm, fibrous tissue, making it profoundly difficult to eat, speak clearly, and maintain even the most basic standards of oral hygiene. The official reported incidence rates, affecting between 1.7% and 3.3% of long-term users, may seem relatively small at first glance. But when you consider the tens of millions of people taking amlodipine, this seemingly small percentage translates into hundreds of thousands of individuals facing significant, painful, and often embarrassing oral dysfunction directly caused by their heart medication. What is particularly alarming and shatters a long-held clinical belief is the emerging evidence that this condition is not solely a problem for those on high doses. It can emerge in patients taking doses as low as 5 milligrams per day, and the first signs can appear within just 6 months of starting the medication, catching both patients and their dentists completely by surprise. The problem typically begins innocuously, with a firm, painless nodular enlargement of the interdental papilla, the small triangle of gum tissue that sits between your teeth. Over weeks and months, this initial swelling slowly and steadily expands, coalescing with the overgrowth from adjacent teeth to form a continuous, thick band of excess tissue that can eventually cover a significant portion of the tooth crowns. Groundbreaking research published in 2024 has uncovered a stark and previously unappreciated gender divide in susceptibility, revealing that men are a staggering 3.3 times more likely to develop amlodipine-induced gingival hyperplasia than women, a finding that points towards a potential hormonal component in the pathology. The current scientific consensus is that amlodipine and other drugs in its class interfere with the normal cellular influx of calcium, which in turn seems to trigger a cascade of inflammatory responses within the gum tissue. This inflammation, driven by molecules like cytokines and growth factors, is believed to stimulate specialized cells called fibroblasts to go into overdrive, producing an excessive amount of collagen, the main structural protein in connective tissue. The result is a dense, fibrotic, and often lobulated mass of gum tissue. These newly enlarged gums can physically push teeth out of their normal alignment, disrupting a person's bite and creating significant orthodontic problems. Furthermore, the overgrowth creates deep, unnatural pockets between the gums and the teeth, known as pseudopockets, which are impossible to clean with a standard toothbrush and floss. These pockets become ideal breeding grounds for dangerous anaerobic bacteria, leading to chronic inflammation, painful secondary infections, severe bad breath, halitosis, and frequent bleeding. The functional consequences are profound, directly impacting a person's ability to chew food properly, which can lead to nutritional deficiencies and even altering their speech patterns. Perhaps the most disturbing and frustrating aspect of this condition is that the problem may not simply resolve itself even after the offending drug, amlodipine, is discontinued. In many cases, the overgrowth can be so severe and persistent that it requires a surgical procedure called a gingivectomy, where a periodontist must use a scalpel or laser to physically cut away the excess tissue, re-sculpting the gums back to a healthy contour. The fact that surgical intervention is often necessary suggests that the drug may be causing deep-seated, potentially permanent cellular changes within the gingival fibroblasts. A sobering thought for anyone relying on this medication long-term. ARSHA. An attack on the kidneys, acute injury, and nephrotoxicity. There is a profound and cruel irony in the fact that a medication so frequently prescribed to protect the kidneys from the long-term damaging effects of high blood pressure can, under the wrong set of circumstances, become their most potent and immediate enemy. While amlodipine is generally considered to be renal-sparing and safe for kidney function at standard therapeutic doses, it holds the latent and dangerous potential to cause acute kidney injury, AKI. A sudden, severe, and potentially irreversible shutdown of these vital organs. This catastrophic event most typically occurs in situations of acute overdose, whether accidental or intentional, or when amlodipine is combined with other medications or conditions that place significant stress on the renal system, such as potent diuretics, non-steroidal anti-inflammatory drugs, NSAIDs, or severe dehydration. When acute kidney injury strikes, it is not a slow decline. It is an abrupt cessation of function. Your kidneys, the body's master chemists and filtration plants, suddenly stop filtering metabolic waste products like urea and creatinine from your blood. This allows these toxic substances to rapidly build up to dangerous, poisonous levels, a condition known as uremia, effectively poisoning your entire body from the inside out. The delicate balance of electrolytes, such as potassium and sodium, is thrown into chaos, and the body's fluid levels can no longer be regulated, leading to massive fluid overload, which in turn can cause pulmonary edema, fluid in the lungs, and heart failure. Extensive medical research and case reports have meticulously documented numerous instances where amlodipine intoxication has directly led to oliguric acute kidney injury. The term oliguric is a precise clinical descriptor for a drastic and alarming reduction in urine output, with the body producing less than 400 milliliters of urine in a 24-hour period, compared to the normal daily output of 1,200 to 1,500 milliliters. This dramatic drop in urine production is a clear and unambiguous signal of severe, ongoing kidney distress and is often one of the first signs of impending renal failure. The underlying mechanism is tied directly and inextricably to the drug's primary pharmacological function, vasodilation. In an overdose situation, amlodipine causes profound and widespread relaxation of the blood vessels, leading to a state of severe hypotension where the systemic blood pressure falls to critically low levels. The kidneys are highly dependent on a consistent and adequate level of blood pressure to function. This pressure is what physically pushes blood through the millions of tiny, delicate filtering units known as glomeruli. Without sufficient perfusion pressure, this filtration process, known as the glomerular filtration rate, GFR, grinds to a halt. The kidneys, starved of the blood flow they need to operate, simply shut down in an act of self-preservation that paradoxically leads to systemic failure. The evidence strongly indicates that this damage is dose-dependent, meaning the higher the concentration of amlodipine in the bloodstream, the greater the degree of hypotension and the more severe the resulting kidney injury. Patients who suffer from this devastating complication require immediate and aggressive medical intervention in an intensive care unit. They may need powerful vasopressor drugs to artificially raise their blood pressure and restore perfusion to their organs, and most will require emergency hemodialysis, a procedure where their entire blood volume is circulated through an external machine to be cleaned of toxins, a function their own kidneys can no longer perform. While recovery from amlodipine-induced AKI is possible once the drug is cleared from the system, it can be a long and arduous process taking weeks or even months, and a significant number of patients are unfortunately left with permanently diminished kidney function, facing a future of chronic kidney disease. DUSTER, a catastrophic skin reaction, Stevens-Johnson syndrome. Among the most feared and horrific adverse drug reactions in the entire lexicon of modern medicine, Stevens-Johnson syndrome, SJS, represents a horrifying, explosive, and potentially fatal immune system meltdown. Though statistically rare, with an estimated incidence of approximately 7 cases per 1 million amlodipine prescriptions, the sheer devastation it inflicts upon its victims makes it a critical and unforgettable risk. SJS is not a simple rash or a common allergic reaction. It is a violent, widespread, and excruciatingly painful hypersensitivity reaction where the body's own immune system launches a catastrophic attack against its own skin and mucous membranes, causing them to die and detach. The ordeal often begins deceptively, masquerading as a common flu-like illness with non-specific symptoms such as a high fever, a persistent sore throat, fatigue, and a general feeling of being profoundly unwell. This benign-seeming prodrome gives the patient a false sense of security, delaying diagnosis and treatment. But within days, the true horror of the condition begins to unfold with terrifying speed. A painful red or purplish rash erupts across the trunk and face, spreading rapidly. This rash is not the primary event, but rather the prelude to the characteristic and defining feature of SJS, the formation of blisters and bullae. Then, in a process that is as medically shocking as it is agonizing for the patient, the top layer of the skin, the epidermis, begins to separate and peel away from the underlying dermis in large, continuous sheets, leaving vast areas of raw, weeping, and exposed tissue that are exquisitely sensitive and highly susceptible to infection, similar in appearance and management to a severe third-degree thermal burn. This catastrophic process of epithelial necrosis is not limited to the external skin. It also viciously attacks the delicate mucous membranes lining the mouth, nose, eyes, genitals, and even the entire respiratory and gastrointestinal tracts. The pain is often described as unimaginable, as the raw surfaces of the mouth and throat make swallowing, eating, or even drinking impossible. The mortality rate for SJS is a stark 5 to 10%, but for its more severe and extensive form, known as toxic epidermal necrolysis, 10, where more than 30% of the body's skin surface is affected, the the death rate can soar to a terrifying 50%. Patients who succumb to the condition often die from overwhelming complications such as rampant infection and sepsis originating from the denuded skin, severe pneumonia from sloughing of the bronchial lining, profound dehydration from massive transepidermal fluid loss, and ultimately, multiple organ failure. The progression of SJS and TEN is notoriously and terrifyingly rapid, often exploding from the initial rash to widespread skin detachment within a mere 24 to 48 hours. Any patient suspected of having this reaction requires immediate cessation of the offending drug and urgent hospitalization, preferably in a specialized burn unit or intensive care unit where they can receive the multidisciplinary care needed to survive. Treatment is a desperate battle, involving meticulous wound care, aggressive fluid and electrolyte resuscitation, advanced pain management with high-dose opioids, nutritional support via feeding tubes, and often controversial immunomodulatory therapies. For those who survive, the journey is far from over, as they are often left with lifelong debilitating sequelae, including permanent scarring, chronic pain syndromes, pigmentary changes, and severe ocular complications such as corneal ulceration and scarring that can lead to permanent blindness. BARSA, the silent bleeding risk, thrombocytopenia. Your bloodstream contains a vast and vigilant army of tiny, disc-shaped cells called platelets, or thrombocytes, which are the unsung heroes of hemostasis. They are the body's first responders, constantly patrolling the circulatory system, ready at a moment's notice to rush to the scene of any vascular injury, where they clump together to form a primary plug and initiate the complex coagulation cascade to stop bleeding. Amlodipine, in rare but serious cases, can insidiously turn your own body against this vital defense force, causing a dangerous hematological disorder known as drug-induced immune thrombocytopenia, DITP. This condition occurs when the immune system, confused and misdirected by the presence of the drug, mistakenly identifies the body's own platelets as foreign invaders and begins to manufacture antibodies specifically designed to destroy them. These antibodies coat the platelets, marking them for swift elimination by the spleen and liver, causing the patient's platelet count to plummet to dangerously low levels. A normal, healthy platelet count ranges from 150,000 to 450,000 platelets per microliter of blood. In documented cases of amlodipine-induced thrombocytopenia, this number has been observed to drop to a perilous 1,000 per microliter, a level at which the risk of spontaneous, catastrophic internal bleeding becomes critically high. The precise immunological mechanism is thought to involve the amlodipine molecule, or one of its metabolites, binding to a protein on the surface of the platelet. This drug-protein combination creates a new, novel structure, a neoantigen, that the immune system does not recognize as self. In a misguided attempt to protect the body, it mounts a full-scale immune response, creating powerful IgG antibodies to attack and eliminate any platelet carrying this new complex. Without a sufficient number of functional platelets, the body loses its fundamental ability to control bleeding, even from the most minor of injuries. The initial warning signs of thrombocytopenia can be frustratingly subtle and easily dismissed. A person might notice that they are bruising much more easily than usual, with large, dark bruises appearing from minor bumps that they don't even recall. They might find that small cuts, like a shaving nick, bleed for an unusually long time. Overwhelming and unexplained fatigue is also a common symptom, as is bleeding from the gums when brushing teeth or spontaneous nosebleeds. A more specific and alarming sign is the appearance of petechiae, which are tiny, pinpoint-sized red or purple dots on the skin, most often on the lower legs. These are not a rash. They are tiny hemorrhages caused by blood leaking from capillaries under the skin's surface. Because amlodipine has a very long biological half-life, lingering in the body for 30 to 50 hours after ingestion, Its destructive effects on the platelet population can persist for days after the last dose was taken. This makes the recovery process a prolonged and difficult ordeal, often requiring hospitalization for close monitoring. Treatment involves immediately stopping the amlodipine and may include aggressive interventions such as transfusions of donor platelets to temporarily boost the count, and powerful immune-suppressing drugs like high-dose corticosteroids or intravenous immunoglobulin (IVIG) to halt the immune system's attack on its own cells. The silent and insidious nature of its onset makes thrombocytopenia a particularly dangerous side effect, as a patient may not realize the gravity of their situation until their platelet count is low enough to risk a life-threatening hemorrhage in the brain or gastrointestinal tract. A life-threatening swelling, angioedema. Imagine a sudden, rapid, and deeply unsettling swelling that emerges without any apparent cause or warning, distorting your facial features and, most terrifyingly, threatening your very ability to breathe. This is the frightening reality of angioedema, a potentially life-threatening allergic-type reaction that can be triggered by a wide range of medications, including amlodipine. Unlike the more common and superficial skin swelling of hives or urticaria, which involves the uppermost layer of the skin, angioedema involves a rapid leakage of fluid into the deeper layers of the skin, the dermis and subcutaneous tissues, as well as the mucous membranes that line the body's internal surfaces. While the reported incidence for amlodipine-induced angioedema is estimated to be around 0.03%, a figure that might seem reassuringly low, many experts in allergy and immunology believe the true rate is significantly higher, as milder cases are frequently misdiagnosed, attributed to other causes, or simply go unreported. The swelling of angioedema most commonly and dramatically affects the face, causing the lips, tongue, cheeks, and the soft tissues around the eyes to puff up, sometimes to a grotesque and unrecognizable degree, over a period of minutes to hours. While this facial disfigurement is deeply distressing, the true and immediate danger of angioedema lies in its potential to catastrophically obstruct the upper airway. When the swelling affects the tongue, the pharynx, the back of the throat, or the larynx, the voice box, it can physically block the passage of air to the lungs, turning the reaction into a dire medical emergency that requires immediate and expert intervention to prevent death from suffocation. The sensation of a thickening tongue and a tightening throat can induce profound panic in the patient, exacerbating the respiratory distress. There are numerous published case studies that have documented severe angioedema reactions to amlodipine, requiring emergency room treatment with high-dose intravenous steroids and antihistamines to quell the inflammatory response, and in the most critical cases, the use of epinephrine injections and even emergency procedures like endotracheal intubation or a surgical cricothyrotomy to secure an open and patent airway. What makes this particular side effect so insidious and unpredictable is its erratic timing. It is not a straightforward dose-dependent or immediate reaction. Angioedema can occur within minutes of a patient taking their very first dose of amlodipine, or it can perplexingly develop weeks, months, or even years into a previously uneventful course of treatment. This delayed onset is particularly dangerous, as neither the patient nor their doctor may connect the sudden swelling to a medication the patient has been taking safely for a long time. A person might experience a mild, transient episode of lip swelling that they dismiss as an oddity, only for a much more severe, airway-compromising reaction to occur with continued use of the drug. Angioedema is an absolute contraindication. Once a patient experiences this reaction to a medication, it is a critical warning sign from the body that the drug can never be safely taken again. The risk of a subsequent, more severe, and potentially fatal reaction upon re-exposure is simply too high. It underscores the vital importance of recognizing any unusual or sudden swelling of the face, lips, or tongue as a potential medical emergency and seeking immediate care.